Thank you very much. Thanks for joining me this morning. I decided to pick a slightly more mainstream topic than some of my other presentations, and hopefully we'll learn a few things. I'm probably not the best person to talk on the history of prostate cancer screening, having not been around for very long, but it was an interesting read going back into the 80s and learning about when PSA first came out. So objectives for today, we're going to look at history of prostate cancer screening, including PSA, major screening trials, and some of the controversies over screening, and then outline the current CUA guidelines. Obviously, most people have probably read CUA guidelines, and there's not much that I'm going to add. We'll just briefly go over that. So, go back 40 or so years. DRE was initially the gold standard for detection of prostate cancer. Looking for the same things we look for today: asymmetry, nodularity, and induration. And many patients at this time were presenting with late-stage disease, already symptomatic from their often locally advanced or metastatic prostate cancer. 1987 study indicated that DRE was in fact more efficient than PSA, transrectal ultrasound, acid phosphatase, or aspiration cytology for detection of prostate cancer. Around the same time, transrectal ultrasound, and this was a medieval torture device, also known as an early transrectal ultrasound device. Research into transrectal ultrasound started in the 1960s. A few other fields were starting to use it, and so urologists and radiologists involved with urology decided they'd try it out as well. The initial images were poor quality, and it took around 20 years into the 1980s before transrectal ultrasound entered mainstream practice. A study from 1985 showed that if you were doing transrectal ultrasound, you could look for anechoic or hypoechoic lesions to detect prostate cancer. And this wasn't just for biopsy, this was actually for detection of prostate cancer. Sensitivity was 77% in a study from 1991, specificity pretty good at 89%, but the positive predictive value was very low, so lots of people getting tests having positives and not actually having a lesion on biopsy. And then along came PSA, prostate-specific antigen, also known as human kallikrein peptidase 3 or HK3. This was discovered in 1979. It's a serine protease, and its job is to liquefy semen. It's released from prostatic epithelium made by the prostatic luminal epithelial cells. It is highly organ-specific. It's found in seminal fluid in high concentration and in serum. Can also rarely be seen in other breast tissue, breast milk, and adrenal or renal carcinomas, but again, those are rare circumstances. One thing we need to remember, and I'm sure everybody knows, PSA is obviously not cancer-specific. So benign and malignant tissue have similar per cell PSA expression, and elevated PSA is thought to be a result of disruption of the basement membrane and basal layers in the prostate. So this can be caused by prostate disease such as cancer, BPH, or prostatitis, or manipulation of the prostate, biopsy, prostatic massage, or instrumentation. You can see falsely elevated PSAs with ejaculation, which is why we recommend waiting 48 to 72 hours before having a sample drawn, and also in cycling, 10% increase if you're riding over 55 kilometers at a time. Black men have higher PSA per prostate volume than white men, and as we all know, 5-alpha reductase inhibitors drop the PSA approximately by half. So getting on to some of the early research into PSA, going back to New England Journal in 1987, study looking at 700 patients, of whom around 380 had prostate cancer. They compared PSA with prostatic acid phosphatase. A number of findings that we know as commonplace today were picked up here. So in newly diagnosed prostate cancer, the PSA is elevated. As prostate cancer gets up an advancing stage as well as increasing volume, PSA increases. And initially, PSA was actually thought to be primarily used for detecting recurrence as well as following patients through time rather than screening for prostate cancer. So after a radical prostate, PSA would drop to undetectable levels, you could detect residual disease as well as early recurrence, and PSA could be used to monitor response to radiation therapy. So back in 1987, this was big research, New England Journal. Today it's just common knowledge. Moving ahead to 1991, PSA screening in the US is really starting to boom at this point, and Catalona published again in the New England Journal a study with 1,600 subjects and men 50 years of age or older. If the PSA was greater than 4, and this was a set point or a cutoff point that was used commonly in early studies. So if their PSA was greater than 4, they'd get a DRE and a transrectal ultrasound. If either of those studies showed an abnormality, then they'd go ahead and have a trust biopsy performed. The comparison group was 300 men who had biopsy based on symptoms or abnormal DRE alone, so going back to pre-PSA screening. What they found is that overall, 6.5% of men included in the study had a PSA between 4 and 10. Of these, 22% had a positive biopsy. 1.8% had a PSA greater than 10, and a more significant proportion of positive biopsies at around 2/3 of patients. They determined that you would miss cancer if you did DRE alone in 32%, TRUS alone in 43%, and PSA alone in 21%. What they didn't specify in this paper was the grade of cancer. They did not give any Gleason grading in the article, and they did at least acknowledge that they were going to be detecting potentially low-grade, really clinically insignificant cancers. They said PSA had the lowest error rate of the 3 tests. If you were going to combine 2 tests, it was best to do PSA and DRE, which is still what we're doing today. Another study with about 1,200 patients came out in 1992 in the Journal of Urology, and they had similar findings: PSA 4 to 10, 26% positive biopsy rate; PSA greater than 10, around a 50% biopsy rate. So, looking back, it seemed that, and I'll touch on it, there's an article from 2004 that questions it, but it was a cutoff determined early based on sensitivity and specificity. I didn't include any of the original data. It was the 2...
5%.
So, with the introduction of PSA, the incidence of prostate cancer increased nearly 80% from 1986 to 1991. Prior to 1986, the most common way to diagnose prostate cancer was actually on a transurethral resection of the prostate. In 1988, only 10% of biopsies had a PSA preceding, and this number increased to over 50% within just 3 years. The graph on the left looks at methods of diagnosis. So again, TURP was used commonly early on, and you can see the increase in needle biopsy for diagnosis of prostate cancer. The graph on the right looks at the way prostate cancer was detected, and again, PSA with needle biopsy was on a significant rise in the late 80s and early 90s. I think this is one of the most telling graphs from that time period. This is looking at rate of cancer per 1,000 population year of diagnosis. So you can see that most of the other cancers, this was a paper from 2017, most other cancers had maybe a slight rise in the early 90s and then a slow decline, but prostate cancer jumped with the incidence by over double between 85 to 1992, and then has slowly been coming down, or I guess been coming down fairly quickly since then. In terms of mortality rates, the lower line on this graph looks at deaths per 100,000 males. Mortality peaked in 1993, and as could be guessed, with earlier detection of prostate cancer, there were fewer people dying. Mortality rates have been cut by around 50%. Now, from people in my generation, we remember the 2014 Canadian Task Force guidelines on prostate cancer screening, but the Canadian Task Force was active back in 1991. What they said was that tumor markers like the PSA could be used or are useful in monitoring for detecting residual disease and recurrence and in predicting prognosis. You can also confirm if you have an undifferentiated pelvic tumor or if you have metastatic disease. A PSA would give you an idea as to whether this was prostate cancer or another primary. And as could be expected with limited research done into the value of PSA long-term, there's insufficient evidence in 1991 to support use as an early detection test. This was a paper published in JAMA in 2004 looking at natural history of prostate cancer. So this was 230 or so men recruited from 1977 to 1984. Prostate cancer detected on DRE based on symptoms and then diagnosed with needle biopsy. Mean age was 72 at the time of diagnosis. These men were given no treatment up front until they had local spread or metastatic disease. Once they reached this point, they'd get either orchiectomy or treatment with estrogens. And what they found was that all patients with Gleason 8 to 10 prostate cancer died before 10 years. The other interesting thing that they found was there's a threefold increase in prostate cancer related or prostate cancer specific death after 15 years, which can be seen on the plot here. This is why, as we look ahead to the guidelines, we see most recommendations saying that people need to have a life expectancy of, in CUA guidelines, 10 years or 10 to 15 years before you're really going to see any significant change in prostate cancer-specific mortality. Just for general information, they updated this after 32 years of follow-up. 41% of patients had local progression, 18% metastatic disease, and 17% of men who underwent basically no treatment for their prostate cancer ended up dying of prostate cancer. And then continuing on in the New England Journal, but moving ahead to 2004, this was a study published related to the prostate cancer prevention trial, which was finasteride versus placebo, looking at prevention of prostate cancer. They took men from the control arm, so 2,950 men with a PSA that never went above 4 nanograms per milliliter during the entire study. What they found is that overall, if your PSA was less than 4, 2.3% of men actually had Gleason greater than or equal to 7 prostate cancer. What was taken from this is that the risk of high-grade disease increases with increasing PSA. 6.7% of men with a PSA between 3 and 4 would in fact have what they called high grade, which was actually what we would call intermediate Gleason 7 or greater. And I think this really brought into question that cutoff of 4.0. And later on, I'll show some incidence graphs, and there was actually an increase in incidence in screening at this point, as well as diagnosis of prostate cancer. So, 2008, the US Preventative Services Task Force came out with recommendations. Men younger than 75 years, there wasn't enough information to give a recommendation. Men older than 75 years, they said do not screen, moderate or high certainty that there's no benefit, and they would discourage use of this service. What they talk about is the harms of screening, so discomfort of prostate biopsy, harm of false positive tests, and then treatment-related issues like erectile dysfunction, urinary incontinence, bowel dysfunction, and others. And in the end, what they say is that, and really we haven't gone too far from here to the AUA guidelines from 2013, discuss potential harms and benefits with your patient. You should be informed that there are some gaps in the evidence, and personal preference should guide decision making. This is setting the stage for 3 large trials that were going to come out that all prostate cancer screening guidelines are now based on, and we're going to touch on those. So first of all, prostate, lung, colon, and ovarian screening trial, PLCO. This was published at the same time as ERSPC in 2009 in the New England Journal. So this was a US study, 76,000 patients recruited from 93 to 2001, 10 centers, and the age range was 55 to 74. They had fairly tight screening with yearly PSAs for 6 years, yearly DREs for 4 years, and if the PSA was greater than or equal to 4, again using that old cut point or set point, they would get a biopsy. Now, they weren't forced into having a biopsy, obviously, but they were offered a biopsy. The results, there was no difference in the rate ratio between screening and no screening at 7 years, and 22% increase overall in the incidence of prostate cancer diagnosis. So their conclusion, no difference in prostate cancer mortality at 7 years between screening and no screening. Now, as most of us know, this study is not referenced as commonly as it might have been early on. At 7 years, these findings, only 94 prostate cancer-related deaths had occurred. So of 76,000 patients, very low death rate from prostate cancer. The big thing with this study that we all need to know is that over 80% of patients in the control arm actually had screening at some point during the study. So the contamination is almost as significant as the screening group, where only 85% of patients actually underwent a PSA test. So this study, and we'll talk about it a little bit later, actually looks at organized screening versus opportunistic screening rather than screening versus no screening at all. People in the control arm had, on average, 2.7 tests in these first 7 years of follow-up, and over 45% of patients actually had a PSA before entering the trial. 35% of men with a positive PSA screen underwent biopsy. So again, even for the people who were being diagnosed or being questioned to have prostate cancer, a lot of them weren't actually having a biopsy in the end. Then we'll move on. So same New England Journal, same issue. This is the ERSPC, European Randomized Study of Screening in Prostate Cancer. 182,000 patients from multiple centers across 7 countries throughout Europe. They included an age range of 50 to 74 years, though their core age group was 55 to 69 years old. This was much more close to being a screening versus no screening trial, where there were very low rates of screening pre-study. They started out with PSAs every 4 years, as well as a DRE, and then switched to just PSA. Because there were multiple centers involved, the study, their primary target was a PSA greater than or equal to 3, but some of the sites used their own PSA cutoffs. As could be expected, if you screen for PSA, you'd have an incidence of prostate cancer greater than in the control group. Their rate ratio was 0.80, which was statistically significant. That rate ratio was 0.73 if you looked at men who were actually screened. This was an intention to screen analysis, the 0.8. What they determined was that 1,400 men needed to be screened and 48 men treated for prostate cancer to prevent 1 death. This was 9 years of follow-up. Their conclusion, screening reduces prostate cancer-specific mortality. Limitations to this study, there were some differences at each of the sites between how they were going about doing their screening and the cutoffs that they used. And then our third trial, Goldberg, published in 2010 in Lancet Oncology, 20,000 men taken from a population-based registry, age 50 to 64, so slightly younger. They looked at screening versus no screening, PSA every 2 years until 69 years of age. And they actually had different PSA cutoffs throughout the study. So after the Thompson paper was published in 2004, their cutoff actually dropped down to 2.5, as I guess they felt that there was a risk of clinically significant prostate cancer despite PSAs less than 4. This was after median follow-up of 14 years. Cumulative incidence, again, higher in the screening versus non-screening group. Prostate cancer-related death, the rate ratio was even more impressive than in the ERSPC study, 0.56. And their numbers, 293 men needed to screen, 12 needed to be treated to prevent 1 prostate cancer-related death. Conclusion, screening reduces prostate cancer mortality. Limitations: this was a single city, and some of the patients from this study were actually included in the ERSPC as well, so there's some crossover between the findings. So those are the three main trials. These are the trials that in the CUA guidelines are referenced, and so it's good from a resident perspective to know these three studies. Now, we talked about a little bit earlier about potential complications. So from the ERSPC data, false positive tests and overdiagnosis are two of the main concerns. 75% of men with a PSA greater than 3 would have a false positive test, meaning that they'd have a subsequent biopsy that was negative from ERSPC data. From overdiagnosis, 66%, so 2/3 of patients, had cancers that were overdiagnosed in relation to screen-detected cases. Other complications related to prostate biopsy, some minor complications, hematospermia, things that resolve on their own. Down at the bottom, 3 in 1,000 men would have a complication requiring hospitalization, urinary retention, fever greater than 38 degrees. Some numbers from more recent studies seem to indicate a higher complication rate than just 3 in 1,000. So, moving ahead to 2012, we've now had the three main screening studies be published, and the U.S. Preventative Services Task Force decided that they would recommend against prostate cancer screening with PSA in all men. So changing their 2008 guidelines, now nobody should be screened for prostate cancer. And again, this was weighing the studies that we just looked at with the harms versus potential benefits. They felt that the benefit of screening was too low. Later that year, and in 2014, ERSPC came out with their follow-up data at 11 and 13 years. And same study, just a couple more years of follow-up. The important thing here is that as follow-up progresses year over year, there are fewer men needed to be screened and fewer men needed to be treated to prevent one prostate cancer specific mortality. So the most recent data and what CUA guidelines and most people are basing their recommendations on is that number needed to screen of 781 and the number needed to treat of 27. The Goldberg study published follow-up results after 18 years. Their risk ratio was actually very similar, 0.58. Number needed to screen 139, number needed to diagnose or treat 13. So again, slightly better results from a screening perspective than the ERSPC. And we see a similar trend in both the number needed to, and the NNI is number needed to invite for screening, dropping every year from 12 years through 18 years, and the number needed to diagnose or treat, again, dropping. So as more men die from their prostate cancer, as we saw in the natural history study, 15 to 20 years is where you're really going to start seeing the differences. And I think that data is seen both in the ERSPC follow-up as well as here, where you're having to screen fewer people and treat fewer people for their prostate cancer. And then in 2014, despite having these studies published, despite having this evidence, the Canadian Task Force on Preventative Healthcare came out with their recommendations. And again, weighing risks versus benefits, they felt that the benefits were not good enough or strong enough to outweigh the risks involved with screening. So for men less than 55 years, strong recommendation against prostate cancer screening. For men aged 55 to 69, this was the target age in the ERSPC study. Weak recommendation, moderate quality evidence against prostate cancer screening. And for men 70 years of age or older, and this isn't different from before, don't screen. Overall, in that time, the 2012 guidelines came out. This is from SEER database, published in 2015 in JAMA. The incidence of prostate cancer was already starting to decline. The 2008 guidelines waffled over prostate cancer screening. They were unsure whether there was benefit or not, and so the incidence was declining. The screening rates peaked, it seems, in 2008 based on a large national study. 40% of men were being screened in the past year. And by 2013, after the 2012 guidelines were put out, or recommendations, only 30% of men were being screened for prostate cancer. So both incidence and screening declined post US Preventative Services Task Force. Now, this was a study in 2017 looking at incidence of metastatic prostate cancer, and what they noticed was an increase between 2012 and 2014 of around 2.7% per year in metastatic prostate cancer presentation, and they predict that metastatic prostate cancer the incidence of it will increase by around 1% per year. Another study published in 2014 determined through statistical modeling that the incidence of metastatic prostate cancer presentation would double if PSA screening was ended. So, and this is something that Dr. Gleave wanted me to touch on, how do we compare, or how does PSA screening compare in relation to other fields? So, relative risk related with PSA screening, so that's to prevent prostate cancer-specific mortality, 0.79. Based on the ERSPC data, number needed to screen, 781 for prostate cancer. Breast cancer, relative risk, 0.81. This is looking at all ages with average risk patients. Then a number needed to screen, if you look at young women, 40 to 49, 2,100 patients need to be screened for breast cancer to prevent one breast cancer-related death. That number decreases to 721 for women aged 50 to 59. So prostate cancer and breast cancer are fairly comparable in those prime age groups. Colon cancer has slightly better numbers, relative risk 0.82, but number needed to screen only 377. So PSA not quite the same as colon cancer, but we may see a trend down the road with the ERSPC findings of a decreased number needed to screen and number needed to diagnose.
Do you know guidelines on screening?
So
are they recommended?
Yes, yeah, they're definitely recommended. I can't remember the age at which breast cancer started, but usually 50 because of the number 2,100. Yeah. Then 2017, PLCO puts out their 15-year follow-up. And again, they say there's no reduction in prostate cancer mortality for intervention versus control arm, but at least here they're now admitting that because of the high rate of control arm PSA testing, this is looking at opportunistic versus organized screening, not screening versus no screening. So this study has very little, I think, clinical utility when we're looking at prostate cancer screening. US Preventative Services Task Force has come out with new guidelines. These are in the draft form right now. They have not been published finally. And they're still fairly vague. Grade C recommendation looks better than before, but all they recommend is that you should talk to your patient about potential harms and benefits of PSA screening. They don't recommend against or for screening, they just say you should talk to your patient about it. They admit that screening offers a small potential benefit, but many people are going to have complications or other issues over diagnosis, over treatment, treatment complications, or screening complications with biopsy. And I think what we should all take from this is that everybody is recommending shared decision-making or individualized decision-making as opposed to just population-based screening. And again, they recommend against screening in men over 70 years. No, their stance is that there's not enough data to give a stance. So they... Sorry? So no. They say that there's not enough information. So they say insufficient evidence for men with a family history or for African American men. So it's a very vague guideline, doesn't really tell us to do much at all. And it says there are high-risk populations, but then they say there's not enough information to give an opinion about that either. There is one study that will be coming out, randomized controlled trial over 400,000 patients in the UK. It was an intention to screen trial. Patients were randomized into one of two arms. Now, the randomization process for this was interesting. It was randomized by a GP office rather than by individual patients. So they went around and got GP offices, and they said, your office will recommend screening, and the other offices will not recommend screening. This was really used as part of the Protect trial to screen men for prostate cancer, and then men who had positive screening, positive tests, ended up getting enrolled into the Protect trial, looking at active surveillance versus radiation therapy and radical prostatectomy. So PSA offered to men 50 to 69. They were asked to participate if their PSA was over 3. Interesting, of the almost 200,000 patients in the screening arm, only 65,000 patients actually had PSA testing. In the control arm, they went with National Health Services recommendations, which was just give information to men interested in PSA screening only. So their National Health Services recommendation is not to screen, not to screen. It said just give them some information. So that was the control arm, and the data is not out yet, but will hopefully be out in the next few years. I'm not sure if it's really going to answer too many of our questions though. So, CUA guidelines, 5 questions. Should we screen? When should we begin? When can we stop? How often should it be performed? And are there other tests that we should be using? This came out in CUAJ in 2017. They looked at the same 3 studies that we have already gone over, PLCO, ERSPC, and Goldberg. So, I think this is probably the highlight of the talk. We should screen men with a life expectancy greater than 10 years, or at least we should offer screening to those men. Again, it talks about shared decision-making, there are potential harms and benefits, and we need to talk about that before making any decisions. If you undergo screening, start at age 50, unless you are high risk, which would be age 45, and high risk in CUA guidelines was referred to as men with a first-degree relative with prostate cancer, giving them a 5-fold increase in prostate cancer risk. If you're going to have PSA screening, you should individualize your follow-up or your screening frequency. So if your PSA is less than 1, screen every 4 years. If your PSA is 1 to 3, screen every 2 years. And if your PSA is higher, then screen more frequently. Discontinue screening if you're 60 years of age with a PSA less than 1. You have a very low risk of prostate cancer if that's the case. Discontinue screening if you're over 70 or if your life expectancy is less than 10 years. They put this into a nice little flow diagram. They also recommend that you can consider adjunctive strategies if your PSA is greater than 3, and primarily if you have had negative biopsies, then you can start looking into some of the alternatives. These alternatives include multiparametric MRI. In general, Cancer Care Ontario came out with guidelines earlier in 2017 recommending against population-based use of MP-MRI. So MP-MRI is not standard of care for biopsy-naive patients. It can be used and can increase detection doing MP-MRI with fusion biopsy in men who have already had negative biopsies and still are high risk to have an increase in PSA or a change in their DRE despite negative biopsy. PSA velocity, PSA density, and free to total ratio can all be used to help guide decision making, but should not be used alone. And there's not great data to support any of them individually. So you can add these on to give yourself a better idea and to help guide how frequently you're testing and when to do a repeat biopsy. And then they talk about the 4K score, prostate health index, and the PCA3 test. So these are all tests that incorporate a few different characteristics to try and increase detection of high-grade prostate cancer specifically. And in Canada, you can use them, but they're not recommended for widespread use due to cost, and none of them are covered. and talking to doctors, so it doesn't sound like these are commonly used. Dr. Goldenberg, I'm not sure if you got in. Yeah, it seemed like there was some excitement about them a few years ago, but not a lot anymore. You can also use prostate risk calculators to estimate the risk of clinically significant prostate cancer. So the PCPT or ERSPC both have prostate cancer risk calculators. Supposedly fairly simple to use and can give you an idea, but again, not a perfect test by any means. And then when it comes to biopsy, again, the whole idea of a shared decision-making process. So before you screen, you need to talk to your patient. Before you biopsy, you need to talk to your patient and let them know about the risks and benefits of screening. Quickly looking at EUA and AUA guidelines, just so we know what is happening in the urology world. Don't do a PSA test without talking to your patients first. Offer PSA screening to patients with a life expectancy at least 10 to 15 years, so very similar to our recommendations. Similar recommendations for when to start. Risk-adapted strategy, so if PSA is greater than 1 at 40 years or greater than 2 at 60 years, then you should have reasonably regular follow-up, and then stop if you have a life expectancy less than 15 years. What is different with the EAU guidelines is that they do recommend using risk calculators or the PHI 4K score PCA3 if you have, before you perform a biopsy, to give you a better idea of whether you should do biopsy. So they are using these more commonly in Europe than we are here. I'm not sure about coverage of the tests or costs of the tests in these healthcare systems. AUA guidelines: don't screen if you're under 40. Don't screen if you're under 55, unless potentially high risk. If you're 55 to 69, and again, this is a fairly vague recommendation, let your patient know that prostate cancer mortality is decreased or is affected in 1 man for every 1,000 screened over a decade. Shared decision making, and you can proceed based on the man's preferences. It does not recommend screening or not screening. It recommends having a conversation similar to the US Preventative Services Task Force. And this is where the greatest benefit to screening exists based on ERSPC data. Screen at an interval of 2 years or more. Again, shared decision making. They don't think that there's much difference, but again, this is expert opinion. Not much difference between yearly screening versus screening every 2 years. And if you're over 70 or have a life expectancy less than 10 to 15 years, no screening recommended. So, in general, screening reduces prostate cancer-specific mortality. Small reduction, but there is a reduction there. We should offer prostate cancer screening to men with a greater than 10-year life expectancy based on CUA guidelines. You need to discuss risks and benefits of prostate cancer screening, including overtreatment, overdiagnosis, and biopsy and treatment complications. We should have a shared decision-making process, and for MPMRI, which is something that we're seeing more of here, it's not standard of care for biopsy-naive patients, but can be used in the patient who has already had a negative biopsy.